Hi, everyone. Welcome to another episode of The Heart of the Matter. My name's Bourann. I'm joined by Anisha and Ankit once again to discuss another interesting study that was just published not too long ago. Today, we're going to be discussing the STRIDE trial, and this is discussing peripheral artery disease and in patients with diabetes. PAD is a condition, it affects a lot of our patients. And I think it's something that we don't think about quite as much because we don't have a lot of really good, solid medical therapies to manage patients with peripheral artery disease. It's something that we objectively define, usually with like an ankle brachial index or toe brachial index. But what often affects our patients more so is claudication symptoms, of that ischemia that comes along with it, and ultimately, threat to their limbs at some point down the line if disease gets severe enough. At this point in time, like I was saying, in terms of medical therapy, we don't have a lot of options. We have things like cilostazol, which are used for symptom management for claudication symptoms. But when it comes to really like anything other than that, or anything that could potentially have morbidity or mortality benefit, we don't have a whole lot. And then, of course, on the other end of the spectrum, we have options like revascularization, which are, can be invasive. And so anyway, in the quest for finding something that we can offer to our patients with peripheral artery disease, the investigators of this study wanted to determine if a medication like semaglutide, which is a GLP-1 agonist, could be beneficial in this group. And primarily for symptom management, to offer something other than, the few medicines currently on the market. And so that's kind of the idea here, is that this medication, if it does in fact provide symptom benefit in these patients, we know has evidence of other cardiovascular or cardioprotective, qualities to it. So it could be sort of like a wonder drug in that sense, where we could use it in the spectrum of our cardiovascular disease patients, because the vascular part of cardiovascular is important. It's not just our heart and our blood vessels to our heart, it's everywhere else. So anyway, this study is investigating semaglutide, the injected form, in patients with peripheral artery disease and type 2 diabetes. And Anisha will go more into the methods and kind of like the specific way the study was built.
Yeah, so as far as the methods go, it's a double-blind randomized placebo-controlled trial. So everybody knew that they were receiving an injection that is a weight loss drug. I'm noting that, or it could be a weight loss drug. I'm noting that because it's something that we talk about a little bit in our discussions, but they don't know whether they're receiving the semaglutide or not. It was from October 2020 to July 2024. It was in 112 outpatient clinics in 20 different countries in North America, Asia, and Europe. There were 792 participants. The median age was about 68 years old. It was only 25% women and it was 68% white. Everyone had type 2 diabetes and peripheral artery disease, and they had intermittent claudication. They used the Fontaine classification. In this specific study, they had a Fontaine stage 2A, and the Fontaine classification was chosen rather than the Rutherford classification, which I think a lot of us are maybe more familiar with, because the Fontaine classification specifies a walking distance that could actually be verified at the inclusion, whereas the Rutherford classification is more subjective, with no objective distance to distinguish the class among those with claudication. And the other part of the inclusion criteria was that they had an ankle brachial index of less than or equal to zero point 0.9. The median was 0.75, or a toe brachial index that was less than or equal to 0.7, and the mean was 0.48. So like I said, the participants were randomly assigned. They were using an interactive web response system, and they were assigned to either once weekly doses of the subcutaneous semaglutide, 396 of them, or the placebo, for 396 of them as well for 52 weeks. The primary endpoint was the ratio to the baseline of the maximum walking distance at week 52, measured on a constant load treadmill in the full analysis set. So they obviously they compared how far they could walk on a treadmill at 52 weeks versus when they started the study. Uh, 59% of them had a BMI of less than 30 kgs per meter squared, which is significantly lower than many studies with semaglutide. And like I said, the testing was conducted on a constant load treadmill, and it had a fixed speed of 3.2 kilometers per hour and a fixed incline at 12%. And so they were measured at baseline, 26 weeks, 52 weeks, and 57 weeks. And of note, the 57 weeks was 5 weeks after they stopped receiving the injections. Ankit, do you want to talk a little bit about the results?
Yeah. So Anisha mentioned the primary outcomes. The primary endpoint was the estimated ratio of maximum walking distance at week 52 compared to baseline, as measured on a graded treadmill walking test. So the ratio was 1.13 with a p-value of 0.0004, which significantly favored semaglutide over placebo. There are also other secondary endpoints, both confirmatory endpoints and then supportive endpoints. So some of the confirmatory endpoints included this ratio at week 57, 5 weeks after they stopped medication, the quality of life endpoint, pain-free walking distance at week 52, and then some of the supportive endpoints included ABI, mean change of body weight in kilograms, and then A1C. So as you can recognize, the walking distance was higher in the semaglutide group. The quality of life was higher. The pain-free walking distance was also higher. ABIs were better, and then there was still weight loss in both groups, but still significantly more in the semaglutide group. And then the A1C changes in the semaglutide group versus the placebo were lower. And then also to talk about some of the safety profile of the semaglutide, the risk of serious adverse events was low, and there were no treatment-related deaths. So putting this all together, with the change in mean walking distance, the confirmatory secondary endpoints, the symptom improvement, and then the change in functional status, with a very excellent safety profile, it seems like the use of semaglutide supported these functional improvements in patients with PAD and type 2 diabetes together. So, Bourann, do you want to talk about some of the important points of the discussion that we talked about?
Yeah, absolutely. So I'll start with something that I think is important for us to discuss because a lot of times when we see these studies showing that semaglutide or some other GLP-1 agonist improved some outcome, we tend to associate it with the weight loss that patients experienced. And we know that was one of the main things that they found about GLP-1 agonists is that it could augment weight loss in patients who have, insulin resistance and things like that. But and while there is a weight related component, because we saw that even in the placebo group, there were patients who had more improvement with more weight loss, that there was still a statistically significant difference between the placebo group and the semaglutide group. And so when we look at how semaglutide works, again, GLP-1 agonist, we have to consider that GLP-1 receptors don't just exist in the pancreas. They exist in our cardiac myocytes. They exist in vascular endothelial cells. And so when we think about that, that could suggest that there are primary mechanisms aside from weight loss that are augmenting these results. And that's perhaps why we got a significantly different response in our patients with the semaglutide. And so there's this idea that, these medications, they can be anti-inflammatory, they can reduce oxidative stress, all by, excuse me, increasing glucose uptake among other mechanisms. And so it's not just in the pancreas, it's in our vasculature. And of course, if we can reduce inflammation at the level of our vascular endothelial cells, then we can certainly make improvements with regards to plaque formation and progression. And so I think that's an important point to make, that we don't think that it's just through weight loss that these patients are getting benefit in their symptoms. And then, the other point to make is that although this study did not investigate morbidity and mortality, we're not looking at major adverse cardiovascular events, we're not looking at mortality or, things like that, that there are other studies that suggest that in patients with cardiovascular disease, which is a broad, category, that there is morbidity and mortality benefit to, using semaglutide. So again, although that's not the point of this study, it suggests that this could be a superior drug to something like cilostazol, for example, which does, confer similar benefits in symptom management, but does not have these added benefits of morbidity and mortality. or haven't been seen in other studies. So I think that's an important thing to mention, and that kind of makes this interesting. Um, what other things do you guys think, especially in terms of long-term therapy? Because one of the things we mentioned is that um, we had these patients evaluated at baseline, 26 weeks, and then 52 weeks. So, um,
Yeah. So I can talk a little bit about that. So, as Bourann mentioned, they were evaluated at different time points during the study, so 26 weeks and 52 weeks. So the benefit of semaglutide was apparent as early as 26 weeks, and then it continued to increase at 52 weeks without an apparent plateau. So that suggests that it could be taken and would be positively impacting these patients long term. Um, the 57 weeks, which is 5 weeks after the semaglutide was stopped. Interestingly, although it is significant, the semaglutide group and the placebo group converge a little bit. So that suggests that maybe these effects are with the medication. They don't necessarily stay there if you're not on the medication. And then the last thing I want to talk about, and this is, I think, a common misconception sometimes in patients that are taking GLP-1 agonists, the like thought of sarcopenia. So since the walking distance ended up increasing in both groups and still significantly increasing to a higher degree in the semaglutide group, that might suggest that there are no substantial detrimental effects that occur to the muscle itself in this population. So that might lessen that risk a little. Anisha, do you want to talk a little bit about some of the weight loss that we were talking about as well?
So yeah, there's two parts that I actually wanted to touch on. I mean, I think Ankit, you brought up the fact that at 57 weeks the groups converged, and I think that's an interesting point about semaglutide that we've been discussing kind of as a whole clinically. That once you stop the medication, does the weight loss stop? Do the benefits stop? And this is another study to show that is this a drug that our patients need to be taking long term or indefinitely? Which I know that isn't something that we love necessarily, but we've been discussing, I think, as a whole within the field and within internal medicine in general, and I know in cardiology. Um, Additionally, I wanted to address what Bron brought up, which was the weight loss in both of the groups. I think what's interesting is that, like we said, that there was a significant association between the weight loss and a functional improvement in actually both groups. And there was a significant mean net decrease of 4 kgs more in the semaglutide group versus the placebo. So we were discussing that there could be actually a psychological component of taking an injection, and does the placebo even actually confer of like thinking that you could be have taking a weight loss drug and actually affecting the patients, and that but even that improved their functional status, which I thought that was interesting. But the other part of it is that people with peripheral artery disease actually, and like we noted, the BMI was lower than other studies in some where semaglutide was studied. But PAD tends to have an overall, they have lower weights overall. So if we started with a lower BMI in general in the group that we did, and people that have peripheral artery disease tend to be of lower weight as well, this clearly has that it just reinforces that this is like separate from the weight loss component, even though that does confer an additional benefit. So I thought those two things were just something that I wanted to bring up based on what we both were talking about.
Yeah, the last thing I just wanted to say was so now I guess there's Cilostazol is a class one indication to use in PAD. So semaglutide, I guess, widens our toolbox for those for this population. However, again, as we also talked about earlier, like these patients have both PAD and diabetes, so it's hard to extrapolate that to just the patients that have PAD. But I think that would be an interesting study to do further.
For
And
sure.
thoughts
Yeah.
on
I
potential.
wanted to mention one last thing because you brought up the one more thing, because that is one of the limitations of the study, right? Because these patients do have type 2 diabetes and peripheral artery disease, and we need to really investigate this with peripheral artery disease on its own. But that was one of the groups that, that's the group that they chose, right? But additionally, I think the other limitations of the study, as we like to discuss in academia and in these studies now, is that the perpetual lack of women in studies that are represented. Only 25% of this study was women, and also it was a significant white population as well, which I just don't feel like confers we can't always extrapolate. I know that again, I always reiterate every episode that we don't practice race-based medicine, but there are different genetic factors, and there are different socioeconomic factors that affect different races in different countries and in different regions. So I just think when we do these tests on white men, it is always a detriment to extrapolating it to our broader population. So yeah, that's what I got. Anything else, guys? All right. Well, to the fun part of our of our episode, the even more fun, I guess, part, which is the silly question that I always get to ask. So today, we are going to just talk about something easy. What's everybody's favorite color and why?
Ankit, you want
Ankit.
to go first?
I like blue. Um, I I don't really it doesn't really matter what shade of blue. I just like blue in general. My wife used to like sky blue, so that's important. But it also could just be because I can't see a couple other colors very well. I'm not like really colorblind, but I just really can't tell the shades between red and green. So
I see.
yeah.
Interesting.
Bron, you gotta go next.
My favorite color is pink, which, I don't know. Some people might know. I feel like every time I buy anything that's not like main articles of clothing, I buy it in pink. Um, but when I was a kid, I used to really like purple. And I used to just say it out of default as I got older, but I realized I didn't really like purple. I liked pink. So that's my answer. And any shade is fine, but maybe not like hot pink, like just all the other shades. What about you,
I'm
Anisha?
glad, I'm glad you're getting closer to your truth as you get older. I love green. I love particularly like Kelly and forest green. It just makes me really happy. I don't know, it's very soothing and calming. I tend to also have random green items, like I guess my Apple Watch strap is green because it's just the color that I wear more, and I feel like I wear a lot of green scrubs at the hospital, but I just think it's just a soothing and lovely color. So that's why. And maybe it's just me trying to get closer to nature because I we don't see a lot of nature in Detroit,
That's
but
true.
it's getting better, especially with the change of
Oh,
season.
it's way
So,
better now. Yeah, we
yeah.
do have trees, guys.
Yes, we have trees and we and they bloom and it's lovely. Anyways, well, thanks everybody for joining us for another episode of The Heart of the Matter. We will see you next time. Bye.
Thanks, guys.
Yeah.